Good morning, everyone, and or good day to everyone, I should say. Good morning here in Florida. My name is Dr. Tom Madayag, and I will be your faculty for this webinar. Our topic for today is pulmonary artery catheter and right atrial monitoring. So welcome, everyone, and thank you for your participation. I see that some of you are experienced in the care of patients with pulmonary artery catheters, also known as Swan Ganz catheter, and a majority of you have not, and that is okay. And that is the reason why we're here today, in order to be able to understand why it is that we use a pulmonary artery catheter. So this was the result of the poll. And I would like to ask the same question over here. Okay, half of you have taken care of a patient with a CVP utilizing a monitor. So that is also going to be okay. Thank you very much for participating in the poll. And now I am going to, it gives me an understanding of where you are as far as these particular technologies are concerned. So when we talk about Swan Ganz catheters or pulmonary artery catheters, what comes to mind is, why is it that we have to use a pulmonary artery catheter? In the past, we always just relied on a right atrial catheter, which measures central venous pressure. But now technology has brought us to a far more advanced mechanism to measure hemodynamic pressures within the heart or the cardiovascular system. So pulmonary artery catheters are used to determine hemodynamic stability or status in critically ill patients. In addition to that, pulmonary artery catheters provide information about right-sided as well as left-sided intracardiac pressures and cardiac output. Now, when we measure CVP, we're merely measuring right atrial pressures. But when we utilize pulmonary artery monitoring, we are able, therefore, to measure left atrial as well as left ventricular pressures. There are 5 general indications for the insertion of a pulmonary artery catheter, and they're listed in the slide. Note that the Swan Ganz catheter is used for hemodynamic monitoring. It does not treat the patient. It merely is used for diagnostic purposes only. Now, there's one thing that is important in the understanding of why pulmonary artery catheters are used, but one of that is the contraindication. This is just a reminder at the outset. A relative contraindication of a pulmonary artery catheter is the presence of a left bundle branch block. If this is the case, due to the risk of a right bundle branch block during catheter insertion, external or transvenous spacer should be placed concurrently to prevent a complete heart block. So what am I talking about? I think I'm going to write a little bit over here so that we can understand what it is that I'm talking about. Just hold on. Now, pardon the crowding over here, but let's do it this way. Hold on one moment. Okay, supposing now that I have the heart right over here, and this is the right side of the heart, and this is the left side of the heart. Well, the bundle branches split, one going into the right and one goes into the left. And we said that the contraindication for the insertion of a pulmonary artery catheter is when this is blocked. Now, understand that a pulmonary artery catheter goes into the right side of the heart, both in the right atrium and the right ventricle. And therefore, there's a risk for damaging the right bundle branch. Thus, if we damage the right bundle branch, and there's already a pre-existing damage of the left bundle, what is going to happen? What is going to happen if we damage the right bundle and there's already an existing left bundle branch block? Please type. Anybody? Yes, it will result in complete heart block. So at the outset, I wanted to emphasize that there is a possibility that there's going to be damage to the right bundle during the insertion of a pulmonary artery catheter, and therefore the contraindication for the insertion of a pulmonary artery catheter is the presence of a left bundle branch block. And thus, as a review, we just need to make sure that we understand what a right bundle branch block is going to be and a left bundle branch is going to be. So I'm going to show you in a screen and ask you what bundle is demonstrated or illustrated by this electrocardiographic pattern. Okay, so this is how you responded. A lot of you said right bundle branch block. Some of you said left bundle branch block, and some of you said both. Okay, let me just address the both. If it is both bundle branches that are blocked, you will have a systole, and therefore that would not be the correct answer. Okay, so let's go ahead and discuss what this is. Whenever you have a bundle branch block or suspect a bundle branch block, you always have to look at the 12-lead ECG And in particular, the one that will help you quite a whole lot would be lead V1 or V6. Now, if lead V1 shows you an M pattern, right, over here, as illustrated here, M, meaning to say that it is going to be upright like this. This is going to be a manifestation of a right bundle branch block. Okay, so anytime that the V1 is going to show an upright complex, like an M, this is going to be a manifestation of a right bundle branch block. The opposite would be true for a left bundle branch block. The ECG pattern will show a more predominant negatively deflected waveform. Okay, so that is going to be important. So whenever you are having a patient that is going to go for an insertion of a pulmonary artery catheter, make sure that there's not a right bundle branch block that is present or a left bundle branch block that is present, because these are going to be contraindications for the use of a pulmonary artery catheter. Okay, having dispensed of that, let's go ahead and take a look at the hemodynamic principles that are associated with the insertion of a pulmonary artery catheter. So illustrated over here is going to be the system upon which we're going to try to understand the hemodynamic implications of the insertion of a pulmonary artery catheter. Now, when we insert a pulmonary artery catheter, we go to the right atrium, and if we go into the right atrium, as well as the vena cava, we're therefore able to measure right atrial pressures. What is the significance of right atrial pressures? Well, it gives us evidence of the central venous pressure, which actually is a manifestation of preload, cardiac preload. So what is this term preload? A lot of us oftentimes are going to be confused with what this term is, preload. And preload is, you have a blank screen right now because I would like to write and illustrate in the board or on the screen what I'm trying to say. Okay. So whatever load you bring into the right atrium is going to be what is known as preload. So it's the volume of blood as well as the pressure that is exerted by this volume of blood that goes into the right atrium. So when you have a great preload, therefore, you will also consequently have a great output in normal situations. So what would happen if we increase this preload too much? We are going to tax the heart, and the heart might not be able to deal with it, in particular for patients with conditions wherein cardiac contraction is not going to be very efficient. And so therefore, it is important that we always measure preload. And preload is always going to be a hemodynamic character that can be measured by right atrial pressure, or CVP. So whenever we're measuring CVP, therefore, we're actually measuring preload, or right atrial pressure. Okay? So the insertion of the catheter from one of the main central veins, like the subclavian vein, for example, is going to be one that is going to be characteristic of this particular catheter. So we go into the right atrium as well as the right ventricle. here we are now going to be measuring preload. Now, when the catheter goes all the way through the pulmonic valve and now goes into the pulmonary artery and one of the tributaries there of the pulmonary artery, we're therefore able to measure pressures on the left side of the heart. So how is that possible? How can you measure pressures on the left side of the heart? And why would we want to measure pressures on the left side of the heart? Well, the first thing that we need to understand is that on this particular area, right over on the pulmonary artery, if we inserted this catheter right over here and inflated a balloon, we are therefore occluding the pulmonary artery, and the only pressures that will now be measured will be the pressures on the left side of the heart. Let me repeat that because that was a mouthful. Now, remember now that this catheter is going to go from the right atrium to the right ventricle. We're now measuring right-sided pressures. But once the catheter goes into the pulmonary artery and we inflate the balloon right here, we close the pressures that are coming from here, we're now only detecting pressures coming from this side. And therefore, we are now able to measure left atrial pressures. And left atrial pressures and left ventricular pressures are a reflection of what we call afterload. Okay, so the measurement over on the right side of the heart measures preload. We understand what preload is now, the amount of volume that is delivered to the right atrium and the right ventricle. Afterload is the resistance of the output from the left ventricle. So in other words, when the left ventricle is now and the left atrium is now full of blood, its effort to dump this volume through the aorta is going to be reflected in a pressure called afterload. All right, so I'd like to liken preload and afterload by the following example to drive the point across. So let's say that you are going to move into a new apartment, and now you're going to fill this truck with your furniture. So you're going to fill this with all your stuff that you're going to move into your new apartment. The amount of furniture that you put into this truck is what is called preload. Okay? So the amount of volume that you bring into the right atrium is what preload is going to be. Now, when you arrive at your new apartment, you're now going to unload all the furniture that you loaded into this truck. Now, there are two doors into the apartment. One door is this, and the other door is this. Which door would it be easier for you to unload your furniture? Would it be door A or door B? All right, so a lot of you are saying door B, and the reason why there is going to be an advantage of unloading your equipment to door B is because it offers lesser resistance, isn't it? So the amount of resistance then, like door A and door B, is what we call afterload. So let's take this into consideration as far as the heart is concerned. So let's say now that this is the right side of the heart and this is the left side of the heart. The volume that arrives into the right side is what we call preload. The amount of efficiency that we have in unloading the volume of the left side is what is referred to as afterload. Now, I hope that that's clear for now. And therefore, let's go back to the presentation. And I'm now going to once again tell you the advantage of why we want to measure left-sided pressures as well. Okay, so if we have a catheter that is able to traverse into the right side of the heart, we're able to measure preload. If we have a catheter that is able to detect the pressures coming from this side, from the left side, then we are able, therefore, to measure afterload. And that is exactly the advantage of having a pulmonary artery catheter. So the tip of the catheter right over here lays into the main pulmonary artery where the balloon can be inflated and deflated for measurement of pressures. When we inflate the balloon, we are obtaining what is known as a capillary wedge pressure, also known as an occlusive pressure, which gives an indirect assessment of the left-sided filling pressures. Okay, so during the placement of this catheter, we are able, therefore, to monitor the pressures of each of the chambers that we're going to go through, the right atrium, the right ventricle, as well as the pulmonary artery. And when we occlude this artery, we're therefore able to measure left atrial and ventricular pressures. All right, I'm now going to pause to see if you have any questions as far as this is concerned, because this is the basis of why we do insert a pulmonary artery catheter. Okay. All right. Let's try to understand this catheter, because that's basically what you're going to be focusing on in your interventions as far as assisting in its insertion, as well as in the care of these patients. There are several designs of a pulmonary artery catheter, ranging from a simple catheter that measures PA pressures to complex multiple lumen catheters that also measure cardiac output and other variables. So a Swan Ganz catheter, or a right heart catheter, is actually a quadruple lumen catheter. Quadruple means to say that there are 4 basic lumens with a thermodilution sensor. And this thermodilution sensor right here is going to be attached to a pressure transducer outside the body. And therefore, this is going to be a one that is able to determine the pressures that are going to be present in the heart. So we can measure CVP, right atrial pressures, right ventricular pressures, and pulmonary artery pressures. So first of all, this catheter is, the size of the catheter ranges anywhere from 60 to 110 centimeters in length. And the lumen is anywhere from 4 French to 8 French in caliber. Each of the 4 lumen is placed in a specific distance to the length of the catheter, and each of them has a specific function. So I'm going to enlarge this a little bit so that you could see it better. Okay, so if you could see, there are different lumens that we're going to see in this catheter, and we're going to analyze each one of these lumens one by one so that you will understand what it measures or what it is for. As you could see right over here, this too could be used for cardiac output and continuous oximetry cable connectors. And this one is an injectate port, and so on and so forth. We're going to go to all these ports one by one because it's a little bit complicated, particularly if you haven't seen one or taken care of one. Okay, so let's move forward. As I said, the pulmonary artery catheter is 110 centimeters long. There are markers. There are thin black distance markers. These are the thin lines. And each line is equivalent to 10 centimeters. So they appear at 10 centimeter intervals from the tip to the hub. Now, there's also another line. If you could see over here, there is a thick line. There's a thin line and there's a thick line right here. The thick line are going to be indicators of a 50 centimeter mark. So this means to say that this is 50 centimeters. The implication here is that we need to make sure that we record the distance marking at the start of each shift. You need to make sure what the distance is that has been inserted, so that in the event that the catheter migrates, we'll therefore be able to identify that. So record the distance marking at the start of each shift. Unless the catheter was repositioned, this distance at the insertion site should remain the same as during the previous shift assessment. So, for example, if this has been inserted, there might have been, this one would be the exit one or the exit mark, and this is what you would chart as an 80 centimeter mark, for example. So what does that mean? If you see the marking located at the entrance of the introducer to be 45 centimeters, it means to say that 45 centimeters of the catheter is inside the patient. So let me repeat that. Supposing now that you measured the exit marking as 45 centimeters, what that means is 45 centimeters is inside the patient. Okay, so that is the first important thing to remember, to make sure that you look at the exit mark and chart accordingly what the exit mark is going to be. So generally, whenever we are going to insert the catheter, the right atrium is actually 10 to 15 centimeters from the subclavian vein, or maybe around 20 centimeters from the jugular vein. We usually don't use the femoral vein in order to measure pulmonary artery catheters because they're so far away that it may dampen and therefore it's not going to be accurate. So the sites in which the Swan Ganz or the pulmonary artery catheter will be inserted will either be the subclavian vein or the jugular vein. Let's now take a look at the components and the pertinent points of the pulmonary artery catheter. And the first one is going to be the side arm of the introducer. So it will be something like this. This is a port that actually you can use for the administration of medications. If there are no continuous drips that are being infused through this, you can put a D5 or normal saline at KVO or keep vein open. And when we mean keep vein open, it's 10 mLs per hour to prevent occlusion. Okay, so this is a port that you can use right after the insertion. The other ports that are going to be present is going to be your proximal injectate lumen or hub. This is the blue lumen, also known as the CVP port. This represents the right atrial lumen. If we're going to approximate where this particular lumen opens up to, it is actually the right atrial lumen. And it is approximately 30 centimeters from the tip of the catheter. So therefore, this will be resting within the right atrium. And therefore, you can use it for several things. One, it could be used for infusion. This port can assess central venous pressure and right atrial pressure. And it could also be used to injectate for cardiac output studies. Now, if you use thermodilution as a method to measure cardiac output, this is where you would inject that particular injectate to measure cardiac output. All right, it also can be used to give fluids and drugs. You could also use it to withdraw venous blood samples. However, you must never use this port to infuse vasoactive drugs or other continuous medication infusion, because interrupting the infusion to obtain cardiac output would result in the patient receiving a bolus of medication. So let me give you an example. Supposing now that you're giving a medication here, and that medication is epinephrine or norepinephrine. So now when you do a cardiac output, you're going to have to inject 20 cc's or 10 cc's of normal saline over here. What that would mean is that, therefore, you're giving a bolus of the norepinephrine that has been retained right over in this area. And therefore, that would not be good. Okay? So for those of you who have been doing cardiac output through the thermodilution method, you usually inject 10 mLs of fluid into this port. And therefore, you understand why you should never use this port to infuse vasoactive medications. Now, another question might be, could you infuse blood through this port? Could you infuse blood through this port? Or should you? For those of you who've used a pulmonary artery catheter, can you infuse or should you infuse blood through this port? Yes or no? All right, Jennifer is correct. You should never use this port for blood transfusion. And the reason for that, technically, blood products can be infused through any of the central lines. However, it is preferable that the blue injection port of the right heart catheter should be avoided. Blood products may reduce the patency of this lumen, making measurements of cardiac output impossible. All right. So we would never use this to give blood or to give vasopressors. You could use the introducer port for that matter. All right. The other thing is that we usually have a venous infusion port, also known as a VIP port. This is an extra port. It is white, and this is what you would use to infuse medications safely. So actually, you could begin administration of medications as soon as venous placement of the introducer has been confirmed by pressure measurement. All right. So another port that you're going to have to be familiar with is what is known as the distal lumen or the distal hub. And of course, the distal lumen is going to be right over here, the one that goes all the way to the pulmonary artery. So this is the distal port of the catheter. The port for the distal lumen of the catheter is always going to be connected to a transduced hemodynamic monitoring so that we could therefore measure the pressure waveforms. And at the same time, the pressure waveforms can be displayed as the catheter passes through the chambers of the right heart and into the pulmonary artery. So this is the port that measures the pulmonary artery pressure. Now, for those of you who work in open heart surgery or post-open heart, mixed venous samples can be drawn also from this port. Okay, so how do we maintain the patency of the distal lumen? Well, the patency is achieved by maintaining a continuous flow of heparinized saline, and the rate of infusion is usually 3 cc's per hour. We should never inject, never inject anything into this lumen because it now goes directly into the pulmonary artery. So no drips, no medications, or any other fluids ever in this particular lumen. Okay? And another lumen that we have is the thermistor wire, or the thermo means to say that this is going to measure temperature. So this is located proximal to the balloon right here. And the purpose is to measure pulmonary artery blood temperature. So it includes a temperature sensitive wire. It terminates around 4 centimeters proximal to the tip of the catheter. The terminal portion of the wire, termed the thermistor, lies in one of the main pulmonary arteries, and therefore this is going to be useful for the measurement of cardiac output whenever you use thermodilution. How many of you have used or measured cardiac output by the thermodilution method? Anybody? Okay, so let me just discuss a little bit how we measure cardiac output by using the thermodilution method. All right, so let's see. Okay, so what if we have a catheter that goes all the way to here, which is what we have in a pulmonary artery catheter? The principle here is, what if I gave a solution? So let's say the solution is 95 degrees Fahrenheit, right on the right side of the heart. We measure its distance right over here, or the speed in which this fluid goes all the way right over into this area. And the speed in which this particular fluid that you gave is going to reflect the cardiac output. What do I mean by that? So supposing now that I injected a solution, 10 cc solution of 95 degrees, this particular part of the catheter is now going to detect the change of temperature by the arrival of this bolus of fluid that you gave right over here. The time, therefore, that it traveled from here to here is going to be computed as your cardiac output. So once again, yeah, Marian, it used to be a cold solution, but now we don't do that anymore. We just use a room temperature solution. It used to be that we ice it so that we can determine when it reaches that distal point of the pulmonary artery catheter. So again, the principle is, if this is the heart and this is the lungs right here, and we injected a solution that's 95 degrees right over here, when there's a change of temperature detected over here, that means to say that we can therefore calculate the travel of this blood or this solution from the right atrium to the pulmonary artery tip to be the calculated cardiac output. Is that clear? It's a little bit, what do you call that? Difficult to explain this well. And that's why I wanted to make sure that you understood what the principle is behind the thermodilution method of cardiac output measurement. Any questions? Okay, clear for Dixon. How about the others? Is it? Yes, thank you, Eileen. And the others? All right. We inject 10 mLs. Yeah, and in order to make sure that we did it accurately, we usually do it 3 times and take the average. Okay. All right, so the other thing that is going to be important right over here is that there's going to be an area right over here, which is known as the balloon inflation lumen. So remember that this is attached to a syringe. This syringe is actually something that comes with the kit. It's not an ordinary syringe, and I'll tell you the reason why. So the red port right over here is the balloon port. At the distal end of the catheter is actually right over here a latex balloon rubber balloon, and it has a capacity of 1.5 mLs, which when inflated, extends slightly beyond the tip of the catheter without obstructing it. So what is the purpose of the balloon? Well, first of all, the balloon inflation cushions the tip of the catheter and prevents contact with the right ventricular wall during insertion. So let me illustrate that again. Supposing now that this is the right atrium and the right ventricle, when we insert this balloon, once it goes into the mouth of the right atrium, actually, the cardiologist inflates the balloon. Why is the balloon inflated? Well, the balloon is inflated so that it could migrate or move to the right ventricle as well as the pulmonary artery by following the pressure of blood. What does that mean? So it's a little bit, what do you call that? Difficult to explain. So let me explain it this way. Now, there were two cardiovascular surgeons that loved to sail, and their name was Dr. Swan and Dr. Ganz. And so they were sailing one time, and for those of you who are familiar with sails, there's a sailboat right here, and the movement of this sailboat is dependent upon the wind and its pressure that is exerted against the sail. So therefore, if the movement of air or wind is going to go towards this side, the movement of this boat is going to go this side. So they were sailing one day and they said, you know what? It probably is going to be okay to migrate into the pulmonary artery so that we could measure left-sided pressures by having a catheter and designing this catheter so that when we inflate it, we need not push the catheter to go into the pulmonary artery, but rather we will rely on the movement of blood to propel it from the right atrium to the right ventricle and then into the tributary of the pulmonary artery. And this is exactly why they designed this particular catheter in order to be able to measure pulmonary artery pressures. So do we understand why, therefore, there is a balloon? So the balloon is something that would cushion the tip of the catheter and therefore prevents contact with the right ventricular wall. So if you're putting the catheter without the balloon, what's going to happen is the catheter is going to whip the walls of the right ventricle. If the catheter whips the right ventricle, what is going to happen? What do you think will happen if we whip or beat the endocardial layers of the right ventricle? Well, actually, it will cause ventricular tachycardia and ventricular fibrillation. That is the major effect of you or a catheter whipping the endocardial layer of the ventricle. And therefore, this particular balloon being inflated is now going to soften the movement or the pressures against the walls of the ventricles. Okay? So it acts for that particular reason. And the second reason is also to float the catheter into position and therefore allows measurement of the pulmonary artery occlusion pressure. So what is this pulmonary artery occlusion pressure, also known as a pulmonary artery wedge pressure? So if you recall, if this is the pulmonary artery right here, and we inserted, let me change a catheter right over here. When we don't occlude it, what are the pressures that we're going to be measuring? Pressures that are coming from here, as well as pressures that are coming from here. However, if I inflated the balloon and occluded the pulmonary artery, what pressures are going to be measured? You're only going to measure pressures from the front of the catheter. You no longer are going to have an effect of pressures from the right ventricle. Is that clear? All right. So therefore, the balloon acts to float the catheter into position and allows the measurement of the pulmonary artery occlusive pressure. And pulmonary artery occlusive pressure is the measurement of pressures on the left side of the heart. Okay? Now, I told you about this syringe. It's very, very important that you remember that this syringe should not be lost. It should never be taken away from this port. This syringe is a self-limiting syringe provided in the kit, which prevents the balloon from being overinflated. This stops at 1.5 mLs only. You cannot pull the plunger beyond 1.5 mLs. So it is important to emphasize that the balloon should be inflated with a volume of 1.5 mLs of air or less. The balloon, in addition, should not remain inflated for more than 4 respiratory cycles when you are going to obtain pressures for the left side of the heart. Okay, so you cannot totally inflate it all the time. As I said, it should only be inflated with, less than 4 respiratory cycles. So what can happen if you overinflate this? So supposing now that this got lost, and sometimes it does, and nurses are now going to use a regular syringe, which is not going to be acceptable. If you overinflate, it damages the pulmonary artery. Because you remember, if this is the pulmonary artery and you now overinflate it, what's going to happen? You can rupture this pulmonary artery. Okay? You could also rupture the balloon itself. And therefore, measures to prevent overinflation and rupture should always be undertaken. So every time you inflate the balloon, actually it's going to weaken. And so we don't want to overdo it. So in addition to not overinflating it, when we deflate this balloon, we should never suck on with the syringe. We should allow for balloon deflation to be passive. Do not pull back on the balloon plunger to deflect. Okay? So there are several things that you need to be aware of when you're taking care of this particular part of the pulmonary artery catheter. The balloon port should always be unlocked in the unlocked position. So when we do this, this is going to be locked. When the lines are going to be even, like here, it's going to be open. So It should always be left in the unlocked position, except when you're doing intentional balloon inflation. Now, for those of you who are taking echo right now, how many of you have finished the hemodynamic section on echo? Could you please indicate if you have finished the hemodynamic section on echo? Not yet? Okay. So you will be encountering this. Dixon has finished. So some of you have finished, some of you have not. But basically, this will help you to understand once you go into echo, because that is a very, very big module to finish. Okay. And that's the reason why we're having this discussion today. All right, the pulmonary, the other thing that we're going to have is, why do I have this particular slide? Oh, okay. The reason why I have this particular slide is to drive the point that when you inflate the balloon right here, what you're going to be measuring actually is going to be therefore the pressures of the left atrium and thus the left ventricle. So whenever you wedge this balloon or you inflate this balloon, occluding it, you're therefore measuring left-sided pressures. Okay, let's see. Paul. All right, could you please respond? Okay, so let's see. This is how you answered. Some of you said CVP, right ventricle, pulmonary artery, and 29% of you said left atrial pressure. So you remember now that when you occlude the pressure, what you're measuring, therefore, is going to be anything that's before the balloon. Okay? So when you occlude it at the level of the pulmonary artery, which is illustrated right over here, you're no longer measuring the right-sided pressures, nor are you measuring the pulmonary artery pressure. Actually, you're only measuring the left atrial pressure. Okay, and that's the reason why we have this particular catheter to measure left-sided pressures. So one of the main questions actually that was asked of me in previous classes is, why can't we just insert a catheter into the left atrium? Does anybody have an answer why we do not insert a catheter into the left atrium to measure pressures for a while? What do you have to access in order to get into the left atrium? Is it a vein or an artery? An artery. Very good. So we do not want to have a long-term catheter that's inserted into the artery all the way into the heart. This would be very, very dangerous. And that is the reason why it is going to be much more favorable to have a catheter that enters into or through a vein rather than an artery. Okay. All right. The last port that we're going to talk about is the right ventricular pacer port. Not all the catheters will have this, but this is an optional port in the event that the patient has a high risk for the development of a bundle branch block or a pre-existing bundle branch block, so that you would have a standby to make sure that you have continuous electrical stimulation of the heart. Now, this port is going to be okay to give medications through. However, it usually is avoided because some medications might be caustic, or it might erode the pacer wire. And so when we use this port for medications, it's only with the consent or the order of the physician. So we have now talk about the anatomy of the catheter. And I think what the most important part of this presentation would be the nursing interventions in the care of the patient with a pulmonary artery catheter. So let's begin with your nursing obligations during insertion. As with any catheterization procedure, sterile technique is essential. And you might need extra sterile towels around the head, shoulders, and chest to ensure that aseptic technique is not compromised. So you probably are going to say, are they going to do this procedure in the OR, in the cardiac cath lab, or at the bedside? And it could be done on all three areas. And that is why if you work in critical care, you need to be familiar with this particular catheter or procedure. All right. Sometimes we place the patient in Trendelenburg because this is going to be easier for accessing the veins, the internal jugular and subclavian veins. However, the catheter is actually easier inserted when the patient is placed flat or slightly upright. So again, the position of the patient during insertion is actually the preference of the cardiologist. But basically, if we wanted to facilitate entry or access into the veins in those particular areas, usually Trendelenburg position is going to be favorable. Now, after inserting the pulmonary artery catheter at the 20 centimeter mark, note this, once the catheter is at the 20 centimeter mark, the balloon is inflated with air. And we now understand why the balloon is going to be inflated. Correct? Because this will direct the movement of the catheter all the way into the pulmonary artery. So in other words, the catheter is never inserted beyond the 20 centimeter mark. We don't push it anymore. We allow for the movement of the blood to propel this balloon all the way to the pulmonary artery. Okay, so when the cardiologist inflates the balloon, it usually is very slow and controlled and never surpasses the 1.5 ml, which is the limit of the balloon. Now, whenever we are assisting in this procedure, which even if you are not a cardiac cath nurse or an OR nurse, you are expected to be able to know what your functions are during the insertion, you're going to have to watch the monitor for changes in the waveforms, as well as arrhythmias that might be present. All right, so these are some of the important points during insertion. The balloon will remain inflated during insertion, and we understand why that is. In order for it to passively migrate into the pulmonary artery, while the catheter is passing through the right ventricle, it is possible that PVCs can occur. And therefore, we should always be mindful that ventricular tachycardia or ventricular fibrillation can occur. And therefore, we should anticipate if that is going to happen. We're going to always make sure to remember that the pulmonary artery catheter is a device that softens with warm body temperature. And therefore, it could easily wedge in the capillaries without the balloon inflation. And so we have to be mindful about that. So these are the waveforms that we're going to be monitoring or to be looking at whenever we're going to be assisting in the insertion of that catheter. And as you could see, if it passes through the right atrium, the waveforms are different. If it passes through the right ventricle, the waveform changes again. And if it goes into the pulmonary artery and the pulmonary capillary wedge, the pressures are different. So let me show you the pressures that are going to be observed during the insertion. So I'm going to, this film is silent and I will be narrating it. Okay, so let's see. As the catheter is inserted into the mouth of the right atrium, you notice now that we inflate the balloon and now it is going to propel itself through the tricuspid valve. You could see the right ventricle and then the pulmonary artery. Once it goes into the pulmonary artery, it now is going to lodge into a small tributary, and this would be called the pulmonary artery capillary wedge pressure. So let me repeat this particular illustration again to show you the different pressures that are going to be seen. So let me just stop this and do it once again. Okay. This is the right atrium. Notice the pressures that are going to be noted in the monitor. This is the CVP or right atrial pressures. Then we have right ventricular pressures right over here. And as it migrates into the pulmonary artery, the pressure changes again. And therefore, it's going to reflect the wedge pressure. So you're going to say, I'm never going to understand how to read all those waveforms. And that's exactly why we're going to go through it one by one. So let's begin with the right atrial pressure and the CVP and how it looks like. Okay. So the CVP or right atrial pressure represents right-sided heart preload, as I told you, which is the volume of blood found in the right ventricle at the end of diastole. So CVP is influenced by venous return and cardiac function. So CVP, therefore, is considered to be equivalent to the right atrial pressure, which in the absence of problems of the tricuspid valve should be a reflection of the right ventricular and diastolic volume. So when you're looking at CVP or measuring CVP, you're thinking of preload, okay? It is the amount of blood that is going to be present in the right ventricle at the end of diastole. All right. So the normal CVP ranges, I don't know why I didn't have this in the thing, okay, but ranges anywhere from 2 to 6 millimeters of mercury or 4 to 12 centimeters of water. So this is the normal CVP that is going to be the norm. Okay. All right. So let's go to the next one. And, okay. So this is how you responded. And we're now going to see what the correct answer is. Now, when you monitor CVP through a femoral catheter, this is something that's not actually recommended. The catheter is too distant from the right atrium, and therefore it will not produce a reliable data. So the correct answer to this one is no. Okay? It should not be used as a monitoring parameter for the measurement of CVP. Okay, here's another poll. Okay, so you remember now that this is likened to the amount of furniture that you put in the truck. So the more furniture that you put in the truck, the more volume you're going to have to unload. And thus the correct answer here is going to be, there's going to be more flow. If CVP increases, more blood flow to the heart is going to occur. If there's more blood flow to the heart, therefore, it's going to increase the end diastolic volume. All right? And I already answered this question. Okay, so now let's talk about CVP. What is CVP? The central venous pressure. And what are the factors that affects the central venous pressure? Well, the first one is the skeletal muscle pump. Veins outside the thoracic cavity has valves, so therefore the blood is pushed upwards as a result of muscle contraction. So the blood returns to the heart, which increases blood return. Therefore, this is a factor in determining how much pressure is generated in the right atrium. The other thing is the respiratory pump. When you take a deep breath, the pressure in the abdomen increases, and therefore the volume in the thoracic cavity increases as well, and therefore it increases venous return. And another factor is going to be blood volume. So during inspiration, venous return increases as the thoracic cavity's pressure becomes more negative. And this is going to also be a factor, is going to be your venomotor tone. So if I constrict your veins, what would happen to the pressure of the right atrium? Constriction would increase the pressure and therefore increase CVP. So let's say now that I gave you morphine. Morphine is a very potent venodilator. What would happen to your CVP? Very good. It would decrease it. Now, supposing now that I gave the patient epinephrine. Epinephrine is a vasoconstrictor, both arterial and venoconstrictor. What would happen to your CVP? It would increase. Very good. And that is the reason why venomotor tone is a very, very important factor in altering CVP. So let's take a look at what causes increased CVPs when the following are present, like fluid overload, right heart failure, cardiac tamponade, and all those things that are listed over here. They're going to increase CVP. When this increase is associated with increased blood pressure, the cause of increased CVP is usually an increase in volume or venous return. And the following decreases CVP. When a CVP decrease is associated with an increase in blood pressure, this probably is going to be as a result of a decrease in cardiac performance. So these are the following situations that causes a decrease in CVP: hypovolemia, shock, forced inhalation, or venodilation. So when we give patients nitroglycerin, what would happen to your CVP? If I give a patient nitroglycerin, what would happen to your CVP? You would decrease or drop your CVP. Okay. So now that we have an understanding of that, let's go ahead with the identification of the waveform of the CVP. So when we're looking at the CVP, such as what is illustrated right over here, there are several waveforms that are going to be reflected in the monitor. And that's exactly what we're going to learn about here, okay? So as you could see, this is the CVP waveform, and there are several ascents and descents that you see, and we're going to study each one of them. So the first part of the image is going to be the A wave. Remember A for the atrium. So for those of you who work in intensive care unit, you usually have this multi-display of waveforms. So this is your ECG, this is your blood pressure or arterial pressure, and this is your CVP, okay? So in looking at this CVP, it is advised that you have a printout of the same so that you could analyze it very, very carefully. So the first wave that we're going to talk about is what is called the A wave. A is for atrium. This is the time that the atria is contracting. So the first peak is known as the A wave, which immediately follows the P wave of the electrocardiogram. Because if A is for atrial contraction, what is going to be the manifestation of atrial contraction in the ECG? It is the P wave. So as you could see right over here, it becomes easier if you have a ECG strip superimposed upon the CVP. So merely go down through the P wave, right here, right there, and this is going to be your A wave. So do we now know where to look for the A wave? You have to look at the waveform that corresponds with the P wave. Or better yet, it corresponds to the PR interval in the ECG. Okay, so if you're looking for the A wave, you look for the PR interval. The PR interval is right here, and go down and you say, aha, this is the A wave. So what is the importance of the A wave? This represents the pressure that is generated in the right atrium or when the atrium contracts. This is the movement of volume of blood into the atrium and therefore reflects the compliance of the atrium. All right, so let's go to the second wave of the CVP. We now know where to locate the A wave, right? Where the PR interval is. The next wave of the CVP is what is known as the C wave. Think of C as cusp, the cusp of the tricuspid valve, because this is on the right side. And this is the event that corresponds with the tricuspid valve cusp protruding backwards through the atrium as the right ventricle begins to contract. So if this is the cusp of the tricuspid valve, when the right ventricle contracts, it pushes slightly the cusp of the tricuspid valve, and therefore it is a waveform that immediately follows the excuse me, the R wave of the ECG waveform. So how do we determine where the C wave is? It is the waveform that corresponds to the R wave of the ECG or the middle of the QRS complex. Okay, so what is the importance of this particular waveform? What is the implication of the C wave? The C wave is the pressure that is going to be a reflection of the increase of pressure due to the bulging of the tricuspid valve into the atrium. So whenever we are measuring actually CVPs, we're measuring it at the start of the C wave. So it's not the A wave that we're measuring the CVP. We're going to measure it at the start of the C wave. If the C wave is not visible, then we would measure it at the X descent, which is going to be something that we're going to discuss later on. Now, there's also a term called Z point. The Z point is merely the beginning or the onset of the C wave. All right, so how do you measure the A wave? The A wave corresponds to the PR interval. How do you measure the C wave? The measurement of the C wave is going to be reflected by the QRS complex. Okay, so if you look at the QRS complex and go down like this, then you say this is the C wave. And the last wave, or the next wave, is going to be the X descent. So following the C wave is the major descent in the CVP waveform. So you have two ascents, A wave and C wave, and then the next waveform is the one that goes down, as you could see right here. It's the waveform that goes down. This is known as the X descent, And this is corresponding to atrial relaxation. So how do we know when this happens? Well, it is during mid-systole or in the QRS of the ECG. This is a representation that the atrium is relaxing. And actually, this is the movement of the right ventricle as it descends after contraction. Okay, so A wave, C wave, and then we have the X wave or the X descent. This is going to be within the QRS of the ECG. And the last wave or the next wave of the CVP is the V wave. This represents the filling of the right atrium. And therefore, this is going to correspond at the end of the T wave. This corresponds at the end of the T wave. So all these waveforms, do we all have to know all these waveforms? And the answer to that is not necessarily, but notice that when you have a patient monitored for the right atrium or CVP, there's always going to be your mean CVP displayed right over here. Should we rely on that? And the answer is yes. But whenever we want to have an accurate measurement, we should always have a strip. We record a strip and identify where the C wave or the Z point is going to be. Because you remember the Z point is the onset of the C wave, and this is actually the one that we want to measure the CVP. So this is the importance of all these waveforms. So I hope that I have actually just demonstrated to you the importance of knowing what those waveforms are. So whenever I teach critical care and my students who usually are going to be nurse residents, they're new graduates, and they say, so why do we have to bother looking at all these waveforms? And I say, if you have this number, you need to understand where those numbers are coming from. You want to make sure that the machine is inscribing correctly. So as a matter of routine here in the United States, when you work in intensive care or any area where which uses the monitoring of CVP, we always have to have a printout and locate the Z point so that we know that it corresponds with the reading that's being demonstrated in the monitor. Okay? All right, so there is a question over here. What slide am I in? Yeah. C for cusp, right? That's the clue. C for cusp. Okay, so most of you got that correctly. This is a manifestation of the cusp of the ventricles, the tricuspid valve bulging during ventricular contraction. Okay, so this is how you responded. And the correct answer, of course, is A, which is A wave, right? So this is atrial contraction, A for A wave. And this usually corresponds with the PR interval. Okay, this is just going to be a slide that would be useful for you in reviewing it, what the different waveforms actually manifest. So here is what you would do whenever you are working in the ICU and you have to locate where the A wave is, the C wave is, and the V wave. Are the things that you would do. You would outline where the PR interval is, and that would be corresponding to your A wave, the QRS complex, the C wave, and so on, the T wave, the V wave. All right. So that's how you would do atrial monitoring or CVP monitoring. Okay, so that ends my presentation. The pulmonary artery and all those pressures are going to be displayed, and we're not going to have time to discuss that in detail, but this should give you a prelude to what you will see in echo. It will describe more about the pulmonary artery pressures as well as the pulmonary wedge pressures. So we focus more on right atrial pressures. Okay, so we're now going to play a game, and this is going to help us determine our degree of understanding. And so let's just stop this share, and I'm going to exit. All right. Are there any questions that you have? Okay, for those of you who are new, we're now going to play a game called Kahoot. And the purpose of Kahoot is to assist you evaluate yourself on your understanding. And therefore, to do this, you would use your phone. So if you would just take your phone and go to www.kahoot.it and enter the code that will be displayed on the monitor. For those of you who are new, just go to kahoot.it and enter this PIN number 428597, and then follow the instructions. All right. If you're not able to join in the Kahoot IT, just watch how it's done. You still could learn from this game. The object of the game is to answer as quickly as you can. And whoever answers the quickest correctly, they are the winners. Okay. So let's go ahead and start the game. Okay, the correct answer is 90 centimeters. So let's find out why that is. The thick line is 50, right? This is a thin line. So this is 10. So that's 60, 70, 80, and 90. So remember that each thick line represents 50 centimeters. Its thin line is representing 10 centimeters. Okay, so let's see who answered that correctly. The quickest is Saru, and Faith are the quickest ones to answer correctly. Okay, very good. So whatever is displayed in here is actually the amount of centimeter that is inside the patient's body. Okay, so let's see who got that correctly. A lot of you got it correctly, but Saru, Belle, Eileen, Rita, and Ryan were the quickest. Okay, so the blue port, which is going to stand for venous blood, represents the central venous pressure. And a lot of you got that correctly. So let's see who was the quickest. Saru again, Rita, Eileen, Meg, Dixon, and Saru has the streak with 3 correct answers in a row. Okay, so you remember that the distal lumen is or the yellow port is going to end at the pulmonary artery. You don't want to infuse anything directly into the lungs. So therefore, it should never be used to administer medications. And let's see, Saru still, Rita, Meg, Eileen, and Dixon. Congratulations. Okay, so two of you got this correctly. So let's go through each of the responses. What should you do with the balloon? Balloon should not be inflated more than 4 respiratory cycles. That is correct, right? You should never leave the balloon inflated longer than that. The balloon inflation should be limited to 1.5 ml. That is actually the maximum that you can use in inflating the balloon. And balloon port should be left unlocked except when wedging. All these three are going to be true. Now, this one, when deflating the balloon, withdraw 1.5 cc slowly. You remember that we should allow the balloon to deflate passively, because when you suck it, you're going to weaken the walls of the balloon. Okay? And that is the reason why this is an incorrect statement. So let's see who got that correctly. Saru again, Dixon, Rita, Meg, and Nyayemi all answered this correctly. All right, almost all of you got this correctly. So if you remember the way in which this pulmonary artery catheter was discovered, so to speak, by Dr. Swan and Dr. Ganz, the idea of the sailboat being propelled by the movement of wind. And therefore, this is the same reason why we inflate the balloon at the 20 centimeter mark in order to allow for the passive advance of the pulmonary artery catheter. So let's see. Saru again, Dixon has a streak of 5 correct answers. Congratulations, Dixon. Rita, Nyayemi, and Eileen. Okay, almost all of you got this correctly. So this A over here is going to be your CVP, or right atrial pressure. And of course, the ventricles are going to generate more pressures than the atria, and thus letter B is going to be your right ventricular pressures. And again, the pulmonary artery pressures are going to be different waveforms, as well as the occlusive pressures. So let's see how you all did. 6 of you got that correctly. And so congratulations, Rita, Dixon, Saru, Nyayemi, and Eileen. Again, Dixon has a streak of 6 correct answers in a row. Congratulations. All right, everybody got that correctly, but let's see who was the fastest. The fastest one was Rita, Dixon, Saru, Nyayemi, and Eileen. Congratulations. right. The correct answer is 5 to 12 millimeters of mercury. We did not discuss this, so this is something that you will be getting once you complete your echo on hemodynamics. And nonetheless, some of you answered it correctly. Rita, Dixon, Saru, Nyayemi, and Eileen. Okay, whenever we're doing hemodynamic monitoring, particularly pulmonary artery pressure monitoring and CVP, we always have to level the transducer at the level of the phlebostatic axis. And the phlebostatic axis is defined as midpoint between the anterior anterior chest and the posterior chest, and intersected at the fourth intercostal space. So this is something that you would always do whenever you are setting up patients for hemodynamic monitoring. Is always to level the transducer at the level of the phlebostatic axis or the right atrium. Okay, so this is exactly that area that we're referring to. And let's see who got those correctly. On third place is Eileen. Congratulations, Eileen. On second place is Rita. Congratulations, Rita. And our valedictorian for today is Dixon. Congratulations, Dixon. And runners-up are Nyayemi and Saru. Congratulations. Okay, so once again, I want to thank you for your participation in this webinar. This webinar is aimed at helping you develop skills as well as knowledge in the care of patients before your arrival to the United States or your final deployment to your workplace. So once again, it has been my pleasure to be with you for the past 2 hours or so. And I look forward to meeting you again, so to speak, in the next webinar. Thank you so much. And I will be online for the next 20 minutes to answer any questions that you might have had that I was not able to respond to. So once again, thank you. Have a good night. Have a good evening. Have a good afternoon. And have a good day. And I hope to see you soon. Thank you. Thank you, Dixon.